continuous glucose monitoring. I'm going to move on, not in particular with personal instructions or advices or how to use a CGM, but a more general overview on the current use of continuous glucose monitoring in liver glycogen storage diseases and what could be next steps towards recommendations on the use and clinical targets. We've been using continuous glucose monitoring in our center already for over 20 years. And already my mentor, Peter Smith, was using CGM in that time. And over time, we've gained a lot of real-world experience with CGM, both healthcare professionals and families. And this knowledge is not always acknowledged by others, such as regulators or healthcare insurances, amongst others. And therefore, my colleagues and I designed 2 surveys to document the state-of-the-art of continuous glucose monitoring use in these rare disorders. And I'm today presenting some of these first results. And to start with, I would like to acknowledge Ruben Overduin, who is a PhD student in our center, Sarah Grunert, a colleague in Freiburg in Germany, and Alessandro Rossi, a metabolic pediatrician in Naples, with whom I made this survey. I added this slide yesterday evening for those people who do not know the difference between Holland and the Netherlands. And I would like to draw attention. You don't have to announce yourself, but so on the left panel you see Europe. The blue countries are those countries that collaborate under the umbrella of METAP-ERN, the European Reference Network, and you have to look very carefully to see the Netherlands. So that's why I added the right panel picture. And on that picture, you can see, let me just do this, 6 red bullets. And these are the metabolic centers in our country. So we have only 6 for 70 million people. And then you see the blue area in that picture, and that is the part of the Netherlands which is below sea level. So if the sea is rising, you can see that some of these colleagues need to move to other areas. And amongst them are my colleagues and I from Groningen, because in the top of our country, that's Groningen. Let me see if I... And in the right circled area, or the left circled area, that is containing Rotterdam and Amsterdam, that is the province called Holland. So every time when people tell you they are from Holland, they are from the red area, and everybody is from the Netherlands, and we are not from Holland. I hope that is clear now for everybody. So let's move on. You made pictures, right? Very good. You all know that liver glycogen storage diseases are a group of rare inherited disorders of carbohydrate metabolism. And fasting hypoglycemia with or without ketones is a very common feature. As such, monitoring blood glucose concentrations is paramount in the management and the monitoring of patients with liver glycogen storage diseases. And for decades, this was performed by measurement of capillary blood glucose concentrations. That was the traditional method to assess glycemic control and to confirm hypoglycemias in patients. But during the last 2 decades, continuous glucose monitoring has increasingly received attention for the treatments of our patients. At the moment, CGM systems are medical devices that are officially registered for the use in patients with diabetes from the age of 2 years for the Dexcom or 4 years for Freestyle, respectively. After the introduction of these CGM systems, the glycemic control targets for several parameters, such as time in range or time below range, have been defined for diabetes. And there's nice literature out for the guidance of clinical decisions in this group of individuals. And it is important both for regular care, but also for clinical trials. We all know that continuous glucose monitoring is also one of the secondary outcome parameters in the AAV8 mediated gene transfer study in GSD type 1A patients. However, published data on CGM metrics in liver glycogen storage diseases and other rare disorders are very scarce for various reasons. When I checked PubMed recently, over 10,000 papers could be found about continuous glucose monitoring, but by far most of these are about diabetes patients. There are several reasons why CGM and telehealth have additional value for diabetes patients, and many of these arguments are also valid for GSD patients. In my opinion, professionals and patients are dealing with a vicious circle that should be broken because often CGM is not reimbursed in healthcare for GSD patients, or they have to pay for it by themselves. And the fact that GSD experts cannot be found in every city or town emphasizes the importance of the use of CGM or self-monitoring by families and patients, but also the importance of sharing data. Currently, there is limited published evidence. Insurance companies do not cover the regular use of CGM, and the regulators do not always appreciate the use of these tools. And I really think that we can break this circle by adding new information to it. So the general aim of our survey was to obtain a comprehensive overview of healthcare providers, patients, and caregivers' opinions about the use of continuous glucose monitoring in liver glycogen storage diseases. And we consider these first important steps towards consensus recommendations on the use of them in liver GSD, both in regular care and in clinical trials. And because the companies who market these devices do not have an interest of taking this any further, I think the field is responsible of taking these steps, and that's why we did it. So this slide is summarizing what we did up to now. Together with Alessandro, Sarah, and Ruben, we designed 2 SurveyMonkey questionnaires, and they were distributed to healthcare providers and to caregivers and patients with liver GSDs. And they were sent in February of this year, and with a reminder in March, and the data were collected in March, and we will discuss these data during a final workshop in September of this year. And for the statements that were included in both surveys that allowed us to compare the opinions between patients, caregivers, and healthcare providers, we rated the agreement on a 5-point scale, and a consensus level was considered above 75%. So this is some indication of the response rate. So there were responses from different continents. In red, there were the responses for by only the healthcare providers. If both healthcare providers and patient representatives replied, it is depicted in blue, and in green when only families responded. So in total, there were 150 healthcare providers who answered the survey, and they represent over 3,800 patients that they take care of from 28 countries. The families came from 22 countries, representing 148 patients in total. And you see that the majority represent either GSD1A or GSD1B. Then going to some of the first results. The use of CGM in GSDs differs in several ways according to the intended use of the manufacturers. Because, well, we now confirm that we use this in glycogen storage diseases, but also much earlier than the intended use. So the median age of considering to start using CGM for healthcare providers was 6 months, but even lower for families affected by glycogen storage diseases. This is a graph representing the way families use continuous glucose monitoring. So most of them used it continuously, but around 20% used it intermittently. And there were also other ways of using that, but that was the vast minority. We also asked the healthcare providers what they would consider a clinically meaningful change in the percentage points of time below or in range. So The CGM is continuously monitoring. There are 288 data points per day, so each 5 minutes, and they can be classified being in range, below range, or above range. And that can be expressed as a percentage. So we asked them, what type of change would you consider clinically meaningful? And I see that I swapped some slides, so let me go. And most of the healthcare providers considered a change of 15% clinically meaningful. And I would like to put that in a certain perspective, because for diabetes, this has already been established. And in the diabetes world, a small incremental success or increase or decrease of 5% is already clinically meaningful or considered clinically significant. And that is really different than our colleagues think or answered based on our survey. There's also a very nice perspective on the data analysis of CGM data, and those who are interested in that, I would like to refer to the paper that I demonstrated at the right bottom of this slide. So I have to go back to these slides. This is a graph indicating the different strategies in reimbursements, and I'm not going into the detail of the different answers, but it shows a big variation in reimbursement strategies for both healthcare providers in red and the families in green when using CGM. And some need the reimbursement through the hospital, some through the insurance companies, but in very many occasions it is not reimbursed at all. This is a slide representing the different devices being used at the moment, and again a large variety between Dexcom G5, G6, G7, and the various freestyle sensors, amongst others. We also formulated certain statements to which we asked the responders to reply, and there was a consensus within the group of healthcare providers and also the families on 13 on these statements, and in some statements there was less agreement. So the first statement that everybody agreed on, and if there is an agreement, I depict the field where the data are presented green, and if there is no agreement, it is depicted in red. So everybody agreed that continuous glucose monitoring should be standard of care. It doesn't mean that everybody should use CGM. That's not what I mean, but it should at least be possible to offer this under certain circumstances. Another statement that we really found important to share and to ask opinion about is the use of unblinded CGM. And in the past, we have been confronted with several occasions where a blinding of the CGM was forced. So we wondered what was the opinion by healthcare providers and caregivers, and the majority agreed that the GSD patients should be able to use unblinded CGM. We also asked whether people thought that real-time CGM data access has additional value, and everybody agreed that it has for patients, for caregivers, and for healthcare providers. So this is more or less also defining the standard of care, and you cannot find it in guidelines, so that's why we thought it is important to ask this in these surveys. And the next statements were about the advantages and the disadvantages. We all know that there are several disadvantages in the use of CGM. And again, I don't have time to go in detail too much about them. But if you put everything together, everybody agreed that the advantages of the CGM outweigh the disadvantages. The next statement was whether that ideal CGM values should meet the needs of individual patients. This is literally cited from the guidelines from diabetes patients, and everybody agreed on that topic. And there was also agreement amongst the healthcare providers and the families that general recommendations on ideal CGM values should be defined for patients with liver glycogen storage diseases. Although the majority in both groups agreed with the next statement, they did not meet the consensus level of 75% in the latter two that you see in the bottom of this slide. So the statement CGM-based glycemic targets depend on the liver GSD subtype did not meet our agreement's requirements. And the same is true for the CGM sensor glucose data. We asked the people to respond on the statement whether or not the data should be reported separately for nocturnal and for daytime periods. The reason why we asked that is nicely demonstrated by experiences that we had in our own center and that we published previously. Here you can see the Dexcom glucose curves from a patient who was admitted in our hospital. And in the second day of admission and the third day of admission, during the night, the patient was still receiving continuous nocturnal gastric drip feeding, but we made a dietary intervention and switched towards a cornstarch-based regimen during the night, and then the curves looked like this. So even though the patient on Tuesday and Wednesday was receiving continuous feeds, you see a very fluctuating curve, and once cornstarch was dosed, the curve was very flat. And there are not many situations in medicine where a flat line actually is a good thing, but here you can see it is a good thing. And this also convinced the parents and the boy in that time to proceed with this dietary regimen. Another source of data to support the report of both nocturnal and daytime values came from a study that we did together with Alessandro Rossi in the COVID pandemic, in fact. And we compared the CGM data of 10 GSD1A patients, adults, with published reference values for healthy people or people without glycogen storage diseases. And for several of the parameters we saw depicted in red that these data, if you pull all the data together, that they are significantly different comparing GSD1A with the healthy reference data, even if GSD patients are on a diet. But then we took a more closer look at the nocturnal values, and on the left panel you can see the cumulative data of the night CGM values in the dark color compared to a light gray, the non-GSD people, and at some moments it was significantly higher in GSD compared to non-GSD, and this suggests that these patients at that moment were overtreated during the night. And there are several reasons why that can be the case, but it's one of the reasons why we feel that it is important to look at these data in a little bit more detail. On the right panel, you can see the 10-day CGM data during the night for one of the participants in the study, and when compared to the 9 other GSD1A patients, and you can see that this patient was really abnormal when compared to the rest of the cohort. So going back to the statements that we asked opinions about in the surveys, everybody agreed that integrating information on physical activity and the actual diet is important when interpreting the CGM data. But not everybody agreed on the statement whether a level 1 hypoglycemia, so low CGM values below 3.9 or 70 milligrams per deciliter, should be considered an alert threshold. Everybody did agree that level 2 hypoglycemia, so below 3.0 or 54 milligrams per deciliter, should be considered clinically significant. So then, taking a look again at what has been published about diabetes in the past, for diabetes it is stated that the level 1 hypoglycemia is considered an alert threshold. So this is the last page of statements, and everybody agreed that the first priority is to reduce time below range, so the hypoglycemia range, and then address the time in range or the time above range. But not everybody amongst the caregivers agreed with the last statement that it is important to assess not only hypoglycemia but also hyperglycemia after meals. So there are several points of discussion or consideration with this study. Of course, there is a high risk of selection bias because we can only reach out to the people who we can reach out to, and we all know that there are also groups of patients who do not have the opportunities to attend patient meetings, who are not a member of patient organizations, who are not very active on social media, who have difficulties already maintaining the balance in their normal life, who often have difficulties even in coming to the clinics. And if reimbursement is an issue in those patients, they would never be reflected in this survey. Another consideration is, of course, that even though there is a lot of literature from the diabetes world, diabetes is a different disease compared to liver glycogen storage diseases. So every time when extrapolating or comparing with diabetes, we have to keep that in mind. And well, like I said before, the aim for glycemic control in general, they are not yet defined for liver GSD, and CGM data is just a part of that. The different GSDs might be very different in the way they are reflected by CGM, and also age-dependent factors may be more important for hypoglycemia disorders when comparing these data sets with the diabetes data, for instance. So to conclude, I think we have really nicely shown that the off-label use of CGM is reality, and it is not according to the intended use as defined by the manufacturers. And it is important that we document it in the literature, and hopefully, it's anyway the last slide, and hopefully that is supporting future steps towards reimbursement, not only in our country but also in other countries. Well, we've seen that. Is it a sign that I should stop? Well, we've seen that CGM is considered standard of care both by healthcare providers and by GSD families, but that reimbursement is still a challenge. It is interesting to look at literature about other diseases, rare diseases, where there's also hypoglycemias, like congenital hyperinsulinism, for instance. And we definitely need consensus recommendations or guidelines on the use of CGM in liver GSDs, both in healthcare and in clinical trial. And I think that's by using that last statement about the guideline, then we are back where we started on Friday evening. Thank you for your attention.
Anybody have any questions? We're all worn out. Oh, yep, okay.
So, wow, this might be off topic, but there are cases where finger prick and the CGM don't match. And is that something you can speak to? Like, is that just a timing thing, or is that a equipment sensitivity thing, or?
It can be several things.
Yeah.
Shall I start?
I would imagine.
You add, if you have things to add to me? Or would you like to start first? Yeah.
I'm not sure if you missed my talk, but basically it's important to understand.
I can give you the microphone.
Sure. So it's important when you're thinking about corroboration between CGM and BGM that you understand where the CGM sensor is sitting. It's sitting in the interstitial space, so it's measuring interstitial blood glucose values, whereas your blood glucose meter is measuring capillary blood, and it takes time for diffusion from the capillary blood into the interstitial space. So it can lag about 10 to 15 minutes behind what we consider the true like standard of care blood glucose finger stick value,
Okay.
especially during periods of rapid change. So we tend to check our children's blood glucose when we think there's a problem, right?
Yeah.
And that's when rapid change is occurring. So when you have that value and you compare it to your CGM, you might think, is this device working? Well, it's a period of rapid change, so it's going to be lagging behind what the BGM is saying. But it's important to note that it's seeing the trend, and then when you get to a period of stability, that you can recheck and make sure that actually during periods where things are stable and there isn't rapid change, that it's actually got that 20/20 corroboration,
Okay.
which is considered the gold standard as far as acceptability. And if it's outside of that and you're wearing a Dexcom, then there's an opportunity to potentially calibrate if needed.
Okay. And the 20/20, that's 20% up or
20% if it's above 80, and if it's 80 and below, then it's 20 milligrams, the actual
Oh,
number
okay.
of the range.
Okay.
Yeah.
Thank you.
Hello. Is there anywhere that we could find this, your presentation published, or where did you post it?
It's not published yet,
Ah,
but hopefully it will be published this year.
all right. And then when you do publish, it will be located.
So when it will be published?
Where
Oh,
where will it be located?
Well, usually everything that we publish is publicly available through PubMed. You know
Through what?
PubMed? Do you know where to find it?
Okay.
Yeah,
Thank you.
you get help. I see it.
Okay.
Yeah, very good.
Thank you.
You're welcome.
Anyone else? Okay, thank you very much.